Our next speaker is Brian Keller, who runs our lung transplantation group. It's no exaggeration to say that Brian has revolutionized our transplantation group. Our numbers go up steadily, 67 cases last year, 26 or 27 cases this year already. It's been really dramatic. And I hope that you, Brian, will tell us how you do it. It's all yours.
All right. Well, thank you for the introduction, Dr. Kanarak, and it's a pleasure to be here with you all today. Um, each year that we give this presentation, I try to have a theme in addition to some of the basics about lung transplantation. And so I hope that we'll learn a little bit about how lung transplantation as a field has been evolving over the last few years, particularly as it relates to candidate selection. These are my disclosures, none of which are directly related to today's presentation. So over the next 30 to 40 minutes, we'll be talking about how to identify patients for referral for lung transplantation. And then we'll talk about the candidate evaluation and determination for candidacy that we use here at Mass General, but it also is pretty much similar at other institutions. And then finally, I'd like to spend the last few minutes talking about the changing face of lung transplantation, particularly as it relates to changes in the recipient demographics. So lung transplantation is a treatment for end-stage lung disease or advanced lung disease for which no other treatment options exist. The lung diseases for which lung transplant may be indicated are listed here. The number one indication for lung transplant over the last 2 years has been the interstitial lung diseases. Number two, chronic obstructive pulmonary disease. And historically, cystic fibrosis has been the third leading indication for lung transplantation. However, with the introduction of the CFTR modulator therapies, we really are not seeing that many cystic fibrosis patients referred for lung transplant, which is great for these patients. Instead, we are seeing what looks to be an increase in the number of patients with pulmonary hypertension, as well as other less common lung diseases that can lead to a need for lung transplantation. When thinking about a lung transplant candidate and when a lung transplant might be indicated, I think it's very easy to think about the lung transplant window. So this is a graph showing disease progression on the y-axis, starting with no symptoms in the upper left corner of the graph. And as disease progresses over time, you start with patients developing some symptoms. They eventually receive a diagnosis of their lung disease and they start medical treatment. At some point, the disease progresses to the point at which they start to need oxygen therapy. And oftentimes this is the opening of the transplant window. There are certain cases for which a patient who does not require oxygen therapy may have other indications for a transplant, but usually most of the patients that are referred for transplant and ultimately go on to receive a transplant are requiring oxygen either at rest or with exertion or both. This transplant window is not a never-ending opportunity. There are chances that the patient's disease can continue to progress. They can develop respiratory failure, malnutrition, and other comorbidities associated with progressive lung failure. And patients can proceed out of this window, becoming too sick for transplant. And so our goal as a lung transplant program is to identify patients early, get to know them, explain the process, explain the expected outcomes, and what it really takes to undergo a lung transplant, and to try to get them transplanted when they're in this window, when they're as healthy as can be heading into the transplant, but sick enough to benefit from the transplant outcomes. Now, we're going to go over some of the more common indications for lung disease. We're going to specifically talk about indications for referral and timing of that referral. And we're going to start with the number one indication for lung transplant here, interstitial lung disease. So the guidelines currently recommend that patients with idiopathic pulmonary fibrosis or a UIP pattern on their biopsies should still be referred at time of diagnosis. So even though we have these antifibrotic medications which have shown some promise and some efficacy in slowing progression of disease, Because these patients can have an unstable and variable progression with rapid declines during exacerbations, it's still recommended that they seek the care of a lung transplant program at the time of diagnosis so that the process and determination of candidacy can be started early. For all other interstitial lung diseases, we're really looking at a progression of disease, usually over a 2-year time frame. So patients who have a decrease in their forced vital capacity or their diffusing capacity for carbon monoxide of less than 80% for the FVC or less than 40% for the DLCO, or a decrease in their FVC or DLCO of 10 to 15% over a 2-year period would be an indication that a patient may benefit from a transplant referral. Also, if patients are requiring oxygen at rest or exertion, or if they're having progressive disease despite optimal treatment. And this is particularly a situation we see with the inflammatory ILDs where immunosuppression may slow or even stabilize disease, but in the cases where it does not, transplant may be considered. The next most common indication for lung transplantation is COPD. In patients with COPD, we use the Bode score as a marker of disease severity, and I've shown you here on the right side kind of the breakdown of the Bode score, which is a combination of the FEV1, 6-minute walk distance, dyspnea scale, and their body mass index. And they get points for each of these categories. So patients with 5 to 6 points on the Bode scale who also exhibit frequent exacerbations or an increase in their Bode score over the previous 2 years, or evidence of pulmonary hypertension, such as increasing pulmonary artery to aorta diameter on the CT scan, should be referred for transplant consideration. Also, patients who are on maximal therapy and appropriate bronchodilator therapy who continue to have clinical deterioration should also be considered for transplantation. And finally, COPD is the one indication where quality of life can really play a much bigger role than expected survival in terms of when a transplant should be considered. This is because COPD can be a very slowly progressive disease. Patients can be on oxygen for many, many years and essentially unable to carry on their daily activities of daily living without significant symptoms. And quality of life on the other side of transplant, in theory, should improve significantly, although given our current outcomes in transplant, survival could theoretically be shortened. This is a conversation we have with these types of patients in clinic to just make sure that they're very clear on understanding what the potential benefits and drawbacks of transplant may be. The other thing with COPD patients is I always recommend that COPD patients be simultaneously or previously referred for lung volume reduction surgery and or interbronchial valves. Neither of these treatments will have a negative impact on their transplant candidacy, but both of them can significantly stabilize disease and delay the need for transplantation. And so it's an opportunity to stabilize their COPD for a number of years and then offer transplant down the road, thus hopefully extending their overall survival. Now, pulmonary arterial hypertension, as I mentioned, has kind of become the third most common indication for lung transplantation. And here we really rely on the Reveal score. So these are typically patients that have an intermediate to high risk score on the Reveal or a number of other scoring algorithms for pulmonary hypertension. Any patient with significant right ventricular dysfunction despite appropriate therapy, and those patients receiving intravenous or subcutaneous prostacyclin therapies should be considered for referral for transplant. There are a few high-risk variants, such as pulmonary veno-occlusive disease, pulmonary capillary hemangiomatosis, scleroderma, in certain patients that have very, very large and progressive pulmonary artery aneurysms. And these patients are at high risk for sudden death and should be referred early for transplantation. In pulmonary hypertension, when we start to see evidence of secondary organ dysfunction, such as liver or kidney damage, this is a sign that the pulmonary hypertension has progressed and transplant should be considered. And finally, any life-threatening complications such as hemoptysis should also spur an referral. I'm not really talking about cystic fibrosis today. Cystic fibrosis is one indication that we're really looking at progression of disease. So patients with an FEV1 of less than 20% should automatically be referred for transplant. And those with better FEV1s, but with the confounding factors of frequent exacerbations, pulmonary hypertension, frequent hospitalizations, life-threatening complications would all be indications to refer for transplant. But luckily, with the, as I mentioned before, with the CFTR modulators, the numbers of CF patients that we're seeing year to year has really dropped. And in the past 3 years, we've only transplanted 2 CF patients, which is a significant decrease from the years prior. Now, regarding referral, some key points that we really can receive a referral from anybody. Most of our referrals come for pulmonologists or primary care physicians, but we also can get referrals from pulmonary rehab centers, and patients can self-refer. Oftentimes, programs have mechanisms in place for access, and for example, here at Mass General, through our website, referrals can be placed using the online form, and then following that, a pre-transplant coordinator reaches out to the person placing the referral to acquire more information and start the process. In general, there's no harm in referring too early. What we want to avoid is receiving referrals very, very late in the disease course, because that really limits the time we have to get the patient through the evaluation, onto the waiting list, and transplanted before the disease progresses too much. If a patient's referred and is deemed to be too early for transplant, meaning not needing a transplant in the next 6 to 12 months, we may do one of 3 things. If they have a high risk for progression to needing a transplant, or a high risk of a complication or exacerbation, we may go ahead and proceed with the evaluation. We may just continue to follow a patient without performing the full evaluation, just to kind of check in and see what their disease trajectory is. Or in some cases, patients are very, very early on the spectrum of getting to their transplant window. And those patients may be returned to the referring provider with instructions to re-refer once the patient has developed progressive disease, a new oxygen requirement, or the like. In any case, if you have questions about a patient, their potential candidacy, or potential timing of referral, I always encourage folks to just reach out to us or your local transplant center. We're always happy to talk through a situation and provide guidance on the appropriate steps and timing of sending patients for a referral. So coming back to the transplant window, let's focus a little bit more now on patients been referred, and how do we actually get through the process of evaluating someone for transplant and determining their candidacy. So the general process from a 10,000-foot view looks like this. A referral is received, an initial evaluation is set up, and sometimes we do some initial testing, although it's not the full evaluation. This initial testing allows us to screen patients for things that would be absolute contraindications from the very start, so that we could provide that information to patients up front. If after that initial evaluation, a patient is deemed to be a good candidate to proceed with the rest of the evaluation, we then continue with that. And as you'll see on the subsequent slides, the evaluation is pretty extensive, including we look at really the body as a whole to determine a patient's candidacy. Upon completion of all of that testing, a multidisciplinary decision is made, and this is a decision that includes all members of the transplant team. So this includes our pulmonologists, surgeons, social work, psychiatry, infectious disease, nutrition, pharmacy, as well as evaluations of physical strength and functioning, insurance coverage, and psychosocial support. At that decision, or at that meeting, usually one of 3 decisions is made. 1, the patient is deemed a candidate, and a decision is made to proceed with listing on the waiting list for transplant. 2, a patient may be deemed to be a good future candidate, but listing may be deferred either because things were identified during the evaluation that need a little bit more testing, the patient may be too early and not quite in the transplant window, or other factors that may come up. for example, not a firm social caregiver support team in place. And in those cases, a patient may be deferred or approved for transplant, but deferred listing. And finally, patients may be declined as a candidate, and this is usually due to a combination of comorbidities rather than one specific factor. As you add comorbidities, the risks of a poor outcome increase significantly. And so we try to take all of those factors into account when deciding on whether a patient is a candidate or not. So from kind of a stepping back, in general, a lung transplant candidate is a person with a progressive, disabling, advanced lung disease with a limited expected lifespan without transplant. Other alternative therapies should have been exhausted, with lung transplant really as a last resort. In general, these patients are free from major secondary organ disease, and that's except in cases where we're maybe considering a multi-organ transplant, such as a lung kidney, heart lung, or lung liver transplant. Importantly, these patients all need to be capable of participating in rehab, both before and after transplant. And finally, a strong caregiver team is critical. At our institution, we require at least 2 identified caregivers who can be available to assist the patient with things like getting back and forth to their appointments, helping with medications, and kind of being a second set of eyes on the patient at home after discharge from the hospital to make sure that the patient is having the optimal outcome. And patients have been declined as candidates because of this a lack of this caregiver support. So this is really crucial. So we'd encourage folks, if you're thinking about referring a patient for transplant, talk to them about thinking about who would be their caregiver team so that they can kind of move forward with that after we see them. In all of these cases, these decisions are very complex. And as I mentioned, they require a multidisciplinary approach in order to come to a decision. So these aren't made by one single person, but it's rather a team decision on whether a transplant would be beneficial in each particular situation. Unfortunately, we don't have a crystal ball to tell us who exactly is going to have the best outcomes after transplant. And so to accomplish identifying the patients with the best chances for a good outcome, we undergo an extensive evaluation. And this includes a medical evaluation, functional assessments, and psychosocial evaluation. So as part of the medical evaluation, not only do we look at their lung disease and their progression of their lung disease, but we really look closely at their cardiac function. We look at their GI testing for evidence of acid reflux, gastroparesis, or other gastrointestinal dysfunction that may put the lungs at risk after transplant. Everybody undergoes an infectious disease evaluation, and we also make sure that their other organs, such as their kidney and liver, are working as they should. Health maintenance, such as cancer screenings and vaccinations, need to be up to date. And then towards the end of the evaluation, our surgeons evaluate them for any surgical risks related to prior surgeries, the effects of their disease on their chest wall, and any coronary or peripheral artery disease that may impact our ability to use support such as extracorporeal membrane oxygenation or ECMO, which allows us to support patients through the surgery. For the functional assessments, we perform these at each visit. So patients undergo a 6-minute walk test. They're all required to undergo pulmonary rehab before and after transplant. We have evaluations performed by our dietitian, as well as a physical function battery to determine kind of their disease trajectory and as it relates to frailty, nutrition, and strength. And then finally, as part of the psychosocial evaluation, all patients meet with our social worker and psychiatrists. They're evaluated for drug, alcohol, and nicotine abuse. And we do require abstinence from all drug, alcohol, and nicotine products, as well as marijuana. And this is because some of these medications do interact with some of the transplant medicines afterwards and can cause things such as increased risk for rejection or side effects of super therapeutic levels of transplant medications. They can also impact the patient's ability to psychologically handle the stress of the transplant. Finally, there's a financial services evaluation and a caregiver evaluation that kind of round out the evaluation components. In terms of the testing, there's a significant amount of blood work that's done, and it's often surprising to the patients how much blood is actually drawn at the initial evaluation. And I've listed here the general kind of categories that we evaluate, but there's many, many tests within each of these categories for which we evaluate patients. One in particular I'd like to highlight is the telomere length testing. So we test all patients that are referred for transplant for short telomere syndrome or short telomeres. And this is because shorter telomeres can increase patients' risks for other comorbidities such as liver fibrosis and bone marrow issues. And it can increase their risk for complications such as cytopenias as side effects to our transplant medications afterwards. So while we don't decline or telomere length will not adversely impact someone's candidacy, it may impact how we think about managing their care after transplant. And so that's important to know up front. We also perform a number of imaging procedures and other tests of the lungs, of the heart function, including a right and left heart catheterization or a coronary CT angiography, depending on the patient's risk factors. And then I mentioned the GI testing. We look at gastric emptying, 24-hour pH probes, esophageal manometry, and barium swallows to get an idea of esophageal function, reflux, and gastroparesis. And then finally, I mentioned the health maintenance, so bone density scans and cancer screening, including pap smears, mammograms, colonoscopies, to make sure that those are up to date. We can't transplant patients generally with active cancer, and so that's important. But we do look at cancers more on an individual basis now, given improvements in oncology treatments. And so previously, there was a 5-year kind of hiatus that a patient had to go through since their cancer diagnosis. And now we've been able to shorten that in some cases, depending on the cancer, the stage, and the treatment received, to be able to move patients to transplant sooner. We use all of this testing and evaluation to kind of identify the potential risks for each particular patient. And when the decision to move forward with transplant is really a balance of the potential benefits of transplant, which include expected improved survival and improved quality of life, with the risks of mortality and morbidity from complications related to the surgery, related to other comorbidities, and related to side effects of medications. We have to take this into account with patient characteristics, such as the type of lung disease, their medical comorbidities, and their life expectancy without transplant. And then we also have to balance this with the patient's expectations. What are they hoping to achieve from this transplant? And is that reasonable with their current clinical situation, that we can obtain that and achieve that goal for them? There are some factors that limit a patient's candidacy for transplant. And what I'm showing you here are what are considered absolute contraindications at most all transplant centers. Patients need to be willing to proceed with transplant. Malignancies with high risks of recurrence or death can limit a candidacy. Any other organ failure, so renal failure, liver failure, heart failure, all of those would be absolute contraindications unless considering a multi-organ transplant. There are certain infections such as active HIV, tuberculosis, or disseminated infections that limit our ability to move forward with transplant. And severe psychosocial issues such as active substance abuse, limited functional status with the inability to rehab after transplant, and repeated episodes of non-adherence without evidence of improvement can all limit a patient's candidacy. There are also factors that can vary from center to center based on the center's expertise and experience in terms of a transplant candidacy. I will say with the factors shown on this screen, the more factors that are present in a particular patient, the higher the risk and the higher the likelihood that a patient would be declined for candidacy. So age, there's no longer an age limit for lung transplantation. At MGH, we've performed transplants in patients as old as 77. Obviously, those patients who are over the age of 70 typically need to have isolated lung disease with no other comorbidities and be in relatively good shape. Sometimes patients may need to be bridged to transplant using mechanical ventilation or ECMO. And so that's a consideration at some centers. And then other organ dysfunction, but not failure, certain infections, and psychosocial challenges can all be limiting factors for transplant. Now at MGH, we've been able to accommodate and work with patients with all of the ones shown here in green. We currently do not offer transplant for patients with Mycobacterium abscessus, certain Burkholderia infections is the risk of recurrence after transplant, the risk of spread to other transplant patients, and the significant comorbidities and disease burden that comes with these infections can be too much. We also have a very strict cutoff for weight of a BMI below 35. Now, we understand that BMI is not a perfect surrogate for adipose tissue, and there are patients who have a high BMI in the setting of significant muscle weight, and so we do take that into consideration. But because of complications related to wound healing, mobility, and the like, we do maintain a very strict cutoff there. So once a patient's evaluated and approved for transplant, the next decision is when to list the patient for transplant. And we're really looking at disease progression over the previous 6 months. And what I've shown you here for each of the top 4 indications for transplant, what you'll see across all of them is the development or presence of pulmonary hypertension is an indication to move forward with transplant. The other things include progression of disease over the previous 6 months, the need for non-invasive ventilation, and life-threatening complications. So over the last 12 to 15 years, the number of lung transplants performed worldwide has increased. And what I'm showing you here are the numbers of lung transplants performed in the United States since 2012. So you can see that they've increased from about 1,800 in 2012 to nearly 3,400 in 2024. Along with this increase in the number of transplants, the number of people dying on the waiting list while awaiting a transplant has also steadily declined over the last 12 years. And so this is a great thing to see, but we still know that there's more work to be done, as our goal is to have no one dying on the waiting list and everyone who is an appropriate candidate receiving the opportunity to undergo lung transplantation. Some other changes in the field of lung transplantation is the type of surgeries that are performed. So 10 years ago or 12 years ago, about 2/3 of lung transplants performed were bilateral in nature, but that has evolved, and now nearly 85% of lung transplants performed are bilateral. Single lung transplants are performed, and we do that as well. Those are typically reserved for patients with significant comorbidities or frailty. For example, previous surgery on one side of their chest, for example, a coronary artery bypass where a cardiac graft may be at risk for damage during a surgery if we were to transplant the left side. And so those patients may be offered a single right lung transplantation. So we talked about some of the indications earlier, and I just like to show these graphs to kind of show the changing demographics. So ILD is by far the most rapidly growing indication for lung transplantation and makes up the vast majority of referrals. Again, obstructive pulmonary disease, shown here with the blue circles, remains number 2. And you can see the cystic fibrosis really drop off in around 2019 and drop below that of pulmonary hypertension over the last 4 or 5 years. The other thing that we've noticed in lung transplantation is the changing demographics of the referrals. So the most rapidly increasing and prevalent age group that we see are those patients over the age of 60 and specifically over the age of 70. And that's not shown on here. They're all encompassed in the 65 plus group shown in orange. But as these medications for pulmonary fibrosis, cystic fibrosis, and pulmonary hypertension have been developed and utilized earlier, what we're seeing is that patients' need for transplantation has been delayed and their age at referral is increasing. Now, we've also seen that the level of illness of these patients is also increasing. So not only are we seeing older patients, but we're seeing sicker patients too. And despite that, outcomes continue to improve. Now, I wanted to just close out by talking about a specific age group of patients that are becoming more common, and these are our septuagenarians. So those patients over the age of 70. And so this is data from a study published a few years ago, comparing patients who underwent lung transplant in 3 different age groups: those less than 60 years of age, those 60 to 69, and those over the age of 70. And as you can see, the patients over the age of 70, as I mentioned before, typically had to be in much better physical shape. They had lower incidences of preoperative dialysis. They, in general, were more restrictive lung disease patients, although obstructive lung disease made up about 20%. Most of these patients were not hospitalized, and there were fewer numbers of patients in the 70-year-old group that required hospitalization or ICU level care compared to those patients under the age of 70, and definitely compared to those under the age of 60. Their patients over the age of 70 typically spent fewer days on the waiting list and were less likely to need ECMO as a bridge to transplant. Now, if we look at those patients from that group over the age of 70, and over the course of this study, this is a database study, there were 2,200 patients over the age of 70 that were transplanted. 2/3 of those received single lung transplants and a third bilateral lung transplants. The majority of these patients were male. Most of these patients, again, were restrictive lung disease, with more restrictive lung disease receiving single lung transplants than obstructive lung disease, which tended to get a little bit more bilateral lung transplant. Again, single lung transplants were less likely to be hospitalized or in the ICU, and also less likely to need pre-transplant ECMO. So when we look at the overall survival of these patients, you can see that there are survival differences by age group, with patients under the age of 60 having the best long-term survival, those 60 to 69 having intermediate survival, and those patients over the age of 70 having the lowest long-term survival. Now, I'm not sure that survival is the best endpoint to be looking at, because a healthy patient in these age groups would have this same pattern. We would not expect a 70-year-old patient with generally good health to live as long from that time point as someone who's in their 40s. And so I think we need to be thinking about, as a field, other surrogate endpoints such as quality of life and things that are meaningful to the recipient themselves when thinking about whether transplant is truly beneficial in this age cohort. We also know that in general, bilateral lung transplants, if you take all transplant patients, those who receive a bilateral lung transplant typically have a longer survival. This is generally true, although in the patient cohort over the age of 70, this difference is much smaller. And so this, I think, allows us an opportunity to consider single lung transplant more often in this age cohort than we would in the younger patients. The most interesting aspect of transplant outcomes as it relates to these patients transplanted over the age of 70 is that the major cause of death after lung transplant, if you take everybody, is generally chronic rejection, which is a slowly progressive scarring of the lungs, immunologically driven. We don't see that, though, in those patients over the age of 70 as the major cause of death. In fact, as you can see, even with things like acute rejection, which is a acute form of inflammation that is usually pretty easily treated with steroids, older patients have a lower incidence of acute rejection after transplant. So what is causing our patients to die after transplant when they're over the age of 70? It really comes down to diseases of aging. So malignancy, cardiovascular, cerebrovascular disease, all of these are higher causes of death in patients over the age of 70 than they are in our younger patients. And there's an age-dependent progression, as you can see here, with about 10% indication or 10% cause of death from malignancy or cardio or cerebrovascular disease in those under the age of 60. That increases to 12 to 14% in patients in their 60s, and to more than 14 to 17% in those over the age of 70. And so these are factors that transplant may accelerate. We do know that some side effects of our transplant medications can cause accelerated cardiovascular disease. We know that our transplant immunosuppressants do increase the risk for malignancies, in particular skin cancer. And so while we can transplant the patients over the age of 70, these patients do require increased scrutiny and monitoring after transplant for these diseases of aging in order to give them the longest quality and best quality of life possible. So to wrap things up, I'd just like to leave you with a few take-home points. Lung transplantation is an effective treatment for end-stage lung disease. Potential candidates should be identified and referred early, and patients may be moved forward through the evaluation phase. They may be monitored for progression of disease, or in some cases may be returned to the referring pulmonologist if transplant's not expected to be on the horizon for the next 12 months or so. It's important to counsel patients early about abstinence from tobacco, cannabis, alcohol, and other illicit substances. And the evaluation and transplant listing can be delayed in patients who are unable or unwilling to abstain from these products. Candidate selection is complex and involves balancing the overall risks and benefits to the patient with the patient's own expectations. We also are, as transplant programs, we are stewards of scarce resources. There are still people dying on the waiting list, and so we do have a ways to go to improve the availability of donor organs. And until we have the ability to guarantee that every candidate receives a transplant, we really have to be careful in identifying those patients most likely to benefit from a lung transplant. Lung transplant allocation, which we didn't really talk about much this time, is really based on candidate need and urgency, as well as their overall predicted survival after transplant. And so we take that into account. We update patients' testing to make sure that when they are on the waiting list, that their score on the waiting list is as accurate as possible to reflect their transplant need. Our general wait time on the waiting list is around 1 to 2 months, which is oftentimes a surprise to patients when they're used to hearing about the wait times that you see in kidney transplant, which are on the order of years. And so we need to make sure that patients truly are in that transplant window when they're evaluated and approved and listed for transplant, because the donor offer could become available at any time, and we'd be moving forward with transplant at that point. And finally, I hope I've shared with you that the demographics of the lung transplant candidate continues to evolve. There's no longer a specific age limit, and we evaluate patients on an individual basis, taking into account their individual situation and comorbidities to determine their candidacy for transplant. And so with that, I thank you for your attention, and I'll be back later for the Q&A session. Thank you.